I want to thank everybody for coming. And like I always say, because you guys show up here, thank you. I didn't even know we needed to put the microphone on.
Yeah, there's a button right
Yeah,
in
good,
there,
good. Because all of you make it a point to come here, it makes me a better doctor. It makes me think about new strategies to help you guys, help my family. So today I want to, I especially asked a few people to come. One of them is Dr. Byrne, my colleague, my mentor, my friend. You know, he gives me good advice. He's a heart surgeon at the hospital. The other one who has a gag order, he can't talk to you guys. You may ask him questions, but he may not be able to answer. And that is Joe Simmons. Joe is out there in the front. He is from Novo Nordisk. I also invited Eli Lilly rep, I think his name is Tim Woods, and he refused to come. He said not that he doesn't have time, but he refused to come. So I don't know what the story with that is. At least Joe is a good man. So today I'm going to talk about, I'm a therapeutic nihilist. What that means is that I don't like drugs. Ever since childhood, I think I always had this big cynicism and suspicion that maybe why do we have to use drugs? And it's surprising that I even became a physician, because all physicians do is prescribe drugs. So I've been struggling last 12, 13 years counseling patients on weight loss, lifestyle improvement, fasting, exercise, low carb diet, sleep. But I can see that a number of us are unsuccessful, including myself from time to time. So I've been sort of lukewarm to some of these drugs, actually a couple of these drugs in particular on the top category, as you will see. So I want to kind of explore with you whether the weight loss drugs are any good. And it's a pretty involved presentation. There are 85 new slides that I have made since Saturday. So if some of you have, don't kind of grasp everything and you want to go back to it and look at it, for the first time, I've actually put this talk up on YouTube already. So, this afternoon I recorded it and put it up, so you can go home and say, what he said didn't make sense, let me go back and review it. So I'm going to spend the bulk of my time talking about GLP-1 agonists. And the other three category of drugs that I'm going to use, come on in. I'm going to spend some time kind of warming us up. So if you sleep for the first 15 minutes and then wake up after that, or I'll tell you when to wake up. So I'm going to start out with these drugs, although I want to spend the bulk of my time on GLP-1 agonist. I think Joe will be happy about that. So the first of these drugs is something that blocks fat absorption. So when we eat fat, that fat is in the form of triglycerides. It has to be broken down into glycerol and fatty acids before our body can take it. And in order for that to happen, pancreatic lipase, our pancreas elaborates an enzyme called lipase, and it breaks it down into small pieces, and then it gets absorbed. So this company that makes Orlistat, it's a fat blocking drug. It blocks pancreatic lipase. Fat globules just go through the gut and they are excreted in feces. So you don't absorb fat. So a version of that is available, prescription Orlistat, 120 milligrams. But also you can go to a local pharmacy and get over-the-counter llie, which is 60 milligrams. So you take 2 of those tablets, it would be like Orlistat. You take it twice a day. So this company did an extensive study on them, 1,600 patients in each group. So you can see 1,600 in each group. Predominantly, they were heavy. You can see that their body mass index was 37. which is about 75 to 80 pounds over your ideal body weight. A number of them were pre-diabetic, about 21%. They were relatively young, 43 years. This is the weight loss in them. This is weight loss over 208 weeks of treatment. That's roughly about 4 years. Impressive is what I would say, okay? Started out at about 10% at the first year. At the end of 4 years, it was still around 7%. Now this was this fat blocking drug, Orlistat, plus lifestyle. So lifestyle also had a good impact. It was about, let's say, around 4%. But the drug, nevertheless, did do some good things. Now, one of the things, now this is a busy slide, and of course, I don't like to show busy slides to you, so I always like to simplify. So from this data, what I got is that using Orlistat and having weight loss drops your blood pressure. It also drops your sugar, because as you lose weight, you drop your sugar. You also become more insulin sensitive, so your insulin levels improve. So we are talking about this fat blocking drug. Now, so what do you pay for it? So because you don't absorb fat, the fat gets acted on by our bacteria, you get gas, borborgmi. I don't know, I didn't know whether I could say it properly. That's just basically the gurgles that you can hear. Now, this is a very distressing side effect of this. And I must tell you, when the Xenical came out, I actually tried it. And this is not fun. So you have, just basically you have oily, fatty stools, and sometimes you have accidents. Okay? So this is just basically fat in your stool. Now, this is an important side effect that I want to talk about, because if you don't absorb fat, the fat that remains in the gut binds to the calcium in your food. So the fat is binding to the calcium, it's being eliminated in your stools, and calcium is needed to prevent oxalate absorption. So when calcium, now Kathy, if she's here, she will understand that calcium will bind to oxalate and will be eliminated in the feces. If there is no calcium, are you there, Kathy, anywhere? Yes. Oh, there. Okay. Because she's an expert in calcium metabolism. So what happens is that you have an increased absorption of oxalate, and that oxalate then gets into your kidneys and it causes calcium oxalate stones. So you got to be careful about that. Another thing is that if you don't absorb fat, how many of you take vitamin D, and how many of you we tell, hey, take your vitamin D with your fatty meal, with your fat meal? So if you're not absorbing fat, you'll not absorb fat-soluble vitamins. Also, certain drug levels fall. If you're going to take warfarin, you need to take less of it. So I guess not many of you are interested in llie, are you? Okay, good. So the second drug we want to talk about, it's called, and I spent a lot of time trying to say it right, Qsymia, okay, Qsymia, whatever. It's a combination of a drug called Phentermine. So Phentermine is an upper. It's what is called the adrenaline that our body makes, the epinephrine that we make, which is the fight or flight hormone. So it's a congener of that. And it combines it with Topiramate. So let's see what they do. So a fight or flight drug is very similar to crystal meth or speed. So basically it increases your blood pressure, it increases your heart rate. So if you have high blood pressure or if you have heart disease, you cannot take this drug. And what it is designed to do is it's designed to increase your metabolism and arousal. Now, fortunately, Phentermine is a much less potent version of crystal meth. So you can take it without that kind of complications. Now you're combining that with Topiramate, which is a seizure medicine. It's a downer, and it's much like Valium or Xanax. So on one hand, you're trying to speed up your metabolism, but at the same time, you want to protect your brain by giving you a downer. So they combined the two drugs, and I really had no interest in this drug until I saw the results. So this was a Concord trial, 900 patients in placebo, 900 patients, about 1,000 patients in each group, in the high dose group, 500 in the low dose group. So you must say that this is an impressive study. 2,500 patients recruited, 70% of them were women, which makes sense because women don't have heart disease. If you look at the body mass index, it was 36 to 37, which means that they are 75 to 80 pounds over ideal body weight. The weight loss is impressive. Look at that. 12% weight loss at the end of 56 weeks with the high dose group. Roughly close to 10% with the low dose group compared to placebo. Now, even though it's supposed to increase your blood pressure, weight loss is beneficial. When you lose weight, your blood pressure goes down. When you don't eat, what do I tell people? If your blood pressure is too high, you do fasting, your blood pressure goes down. So blood pressure went down. Another impressive things, the fat and blood or triglycerides went down dramatically. The good cholesterol went up a little bit. Blood sugar went down. Insulin went down. So insulin became more functional. You got insulin sensitive. And A1C went down. So this is A1C slide. This is the insulin slide. Now, what are the problems with Qsymia? One is that it's contraindicated in pregnancy. So if you are going to become pregnant or likely to get pregnant while you take it, it's not a good idea. Also, because of the phentermine component, which is an adrenaline or amphetamine-like drug, physicians are advised to go through risk evaluation and mitigation strategies so that you can counsel your patients properly. I don't think I'm willing to do that. So I don't want to write a prescription for that. What were the downsides? Dry mouth, paresthesias, constipation, all things that you can handle. It's not a problem. But what could be a little problem is anxiety, which was significantly higher. Irritability, you don't want your spouse to be irritable, they'll throw you out of your house. And disturbance in attention. You could not think properly because the topiramate component was a big downer. So you may not have had good cognitive skills when you wanted them. So how many of you are interested in Qsymia? No. Okay. I thought as much. And Joe is very happy. Okay. So the next is another combination drug. It's a combination of Bupropion and Naltrexone. So Bupropion is an antidepressant and it prevents, in our brain, there are nerve terminals that release neurotransmitters called dopamine and noradrenaline or norepinephrine. So what these do, dopamine is a feel-good hormone. Noradrenaline is a hormone that increases arousal. This is the same thing as epinephrine or the fight or flight hormone, but it's at the level of the neurons. So it's making you more aroused, and so that can perhaps make you not want to eat. The second thing that this combination drug has is what's called naltrexone. So in order to explain what naltrexone is something that acts on your reward pathways. In our brain, there are pathways that give you reward. So in other words, I have the desire this evening to go and have a sweet dessert. Flan. Let's say, I have a weakness for flan. So the anticipation of the flan will activate my brain centers. I anticipate the reward, and when I eat flan, I get gratification from that reward, and that's mediated by these centers in the brain that are releasing dopamine. What naltrexone does is that it goes and blocks the dopamine release. So if I have naltrexone on board right now, I'll say, I don't really care for that sweet. I don't want it. Because one is that the desire for that sweet is gone. Two is the reward from eating that sweet will also be gone. Okay? So is that a good thing? So yeah, in many of us it is, but investigators have created what is called dopamine deficient mice. So dopamine deficient mice are mice that are lacking the reward center hormone or neurotransmitter called dopamine. And when dopamine is absent, these mice have no pleasure in living. So you can see the smaller mice out here. It just stays in one place. It does not seek food. It does not seek water. It looks like it has lost the desire to live. But human desire for food is a little too much in this day and age, and perhaps we should curb it a little bit with some drugs. So let's see what Contrave, which is a combination of Bupropion and Naltrexone, did. So in this set of studies, about 600 in each group. That's pretty good, right? Young people, predominantly women, because whenever you have concerns that a drug can cause cardiac side effects, go select women, because women have less heart disease. Body mass index was again 37, so pretty high. Let's see what happened. Again, pretty impressive, don't you think? The weight loss drugs are very impressive in their weight loss. 9%, 7%, and the high dose versus the low dose group. But just as this drug came out to market, okay, let's talk about the side effects first. There was about a 27% risk of nausea, 16% of headache, 16% of constipation, and a little higher risk, about 15% versus 11% of psychiatric disturbance, not feeling good taking that drug. But just as this, nausea increased, headache increased, constipation increased. I was jumping ahead. This is the slide I was referring to. Just as this drug was coming out, 2 weight loss drugs were taken off the market. One of them was Meridia, which is very similar to Bupropion, and the other one was Phentermine. So when this was taken out, the FDA said, hey, we want a cardiovascular safety trial. Do a cardiovascular safety trial on this drug. It'll be good. It's not needed, but do it. So the company started doing it. And when you do a cardiovascular safety trial, you have what is called an interim analysis. You analyze after 25% of patients are enrolled, after 50% of patients are enrolled, and see what direction is the drug safe. So that data was released publicly. And when it was released publicly, the manufacturer decided there's going to be no benefit in completing this trial. Let's stop it. So at the time they stopped, stomach-related gastrointestinal events were 15% versus 2%. Central nervous system were 5% versus 1%. The cardiac risks were never completely evaluated because the trial never went to completion. So basically, I would have difficult time prescribing Contrave. What do you guys think? So I wasted 19 minutes of your time talking about drugs that we're not going to use. So I came here today to just talk about this. Now, these are called incretins. It is surprising to many of us that our gut, that is small intestines, make a lot of hormones. These hormones are called incretins, and today we're going to talk about 2 specific incretins. One of them is called glucose-dependent insulinotropic peptide or polypeptide. It was too hard to say it, so I'm going to just say GIP from now onwards. So just think about this hormone from the gut as GIP. The other one we've been talking a little bit about, which is GLP-1. So what do? It's not surprising that the human body is very intelligent. When you eat food, even before the food hits the bloodstream, there are sensors in our gut that will tell food is coming. Get ready pancreas to put insulin, get ready liver to store sugar. So if I take my arm, put a tourniquet out here, put an IV in here, and I mainline sugar into myself. So in other words, I'm mainlining sugar into myself. The other way I can get sugar into myself is by eating. So in other words, I'm putting sugar in here directly into my vein, otherwise I'm eating it. Which one do you think will produce a more robust and more physiologic insulin response, because I'm putting in sugar, my insulin is supposed to go up. Which one do you think will increase the insulin better and more robustly? Eating, absolutely, because the body is so smart that even before the sugar reaches the bloodstream, it will tell the pancreas, hey, this guy is an American. He's going to eat a lot of carbs. How did that happen? I didn't want that network. Okay. So this is what is happening. So here is somebody being given 50 grams of glucose by mouth and also being given glucose through the vein to keep the glucose levels the same. When the glucose goes through the mouth, the insulin levels go up robustly. When they go through the vein, the insulin levels are flat. They don't go up at all. And the reason why this is happening is because of GIP. So you see GIP out here. The GIP is a signal that is coming from sensors in your duodenum that is telling the pancreas, sugar is coming, get ready to do your performance. And that's an important aspect. Now, GIP is sensing food very early after you eat it. But we have to have sensors to stop eating. If we don't have sensors that tell us, hey, you have eaten enough, you need to stop eating, it's going to be bad, especially if you rely on all the nutrients getting into the bloodstream and then deciding. So the gut has to tell you, hey, I'm already sensing you have eaten too much, please stop. So the function of that is carried out by this second hormone, which is called GLP, which is released a little later in the small intestines. What GLP does is that it goes and tells the pancreas to make insulin and stop making glucagon. I'm going to go and tell you why shutting down glucagon is important in the next few slides. It also has receptors in the brain. We have receptors in the brain for GLP-1 agonists, that are GLP-1, which tells the brain, you're not hungry anymore, you're satiated, please stop eating. It stores fat, it increases heart rate. Now these are the functions of GIP, but here is GLP. Hold on one second. Am I wrong there? This is GLP, this GIP, this will be GLP. Okay. So GLP is telling you, slow down gastric emptying, increase insulin, drop your glucagon, tells the liver to stop making glucose, tells the fat cells to store the fat you have ingested, and tells the brain, you are no longer hungry, you're satiated. Okay. Now, when you eat and GLP is released, it's a little later, so you may still need a little bit more insulin. So GLP senses the glucose coming in and makes the pancreas make insulin. But it does something a lot more important. And I don't know if you can see my cursor here. I'm talking about glucagon. It drops the glucagon levels. Now, this is a little advanced metabolism. But if you know why we need to shut down glucagon when we eat, you have a PhD in human biology. But let me just kind of go over why we need to shut down glucagon. So glucagon is a starvation hormone. When you're starving, the glucagon levels go up, the insulin levels go down, and glucagon goes up because it goes and tells the liver, the glucose that you have stored, now release it into the bloodstream because we need to feed the brain. You're not eating. And if the liver glucose is finished, it then breaks down your muscles and converts the muscles into glucose through the liver, or it breaks down your fat and takes the glycerol from the fat and converts it into glucose. So it's a starvation hormone. It's supposed to be there when you are not eating. But if the levels of glucagon are high, immediately after you have eaten, your liver would not know what to do and it will keep pouring out glucose and your glucose levels go up. So what are the conditions we have very common in this room and in the hospital in which the liver and the pancreas fail to recognize that you have eaten? Diabetes is one of them. When you're a diabetic, the signals that glucagon should be shut down is gone. Even though you have eaten and there is plenty coming in, glucagon gets poured out and your sugar levels go up. Another one of them is obesity with insulin resistance. So the function of GLP-1 is to shut down glucagon. So when you have both GLP-1 and to some extent GIP, their combined effect, and this is redundant, is to slow gastric emptying, is to release insulin, stop glucagon production, stop the liver from putting out sugar because it has to now store sugar. You've eaten a lot of sugar. And at the level of the brain, improve your satiety and reduce your hunger. So this is the point where Novo Nordisk entered the market. And it said, hey, this GLP-1 is a pretty amazing stuff. It does some really good things. But lo and behold, the naturally produced GLP-1 lasts only 2 minutes in our system. Because in 2 minutes, there's an enzyme called DPP4 that comes and inactivates it, it destroys it. So our pharmaceutical industry is very good in altering these molecules so that they stay longer. They don't get destroyed. So one of the first things they did, and I think Liraglutide, which is called Victoza, was released in 2010. But even in 2005, there was already a GLP-1 agonist available. And what they did was they attached a fatty acid at a certain residue in this amino acid chain. And this fatty acid goes and binds to albumin. And when it binds to albumin in our blood, it stays in the system longer without getting inactivated. So Victoza or Liraglutide can stay in the system for 24 hours. So you can do once a day injection and get 24 hours worth of GLP-1 activity rather than that brief activity that you and I get who don't take a GLP-1 agonist. So in other words, our brain is getting only a short-term signal to shut down eating, whereas people who are taking GLP-1 are getting a continuous signal in their brain to say, hey, you are not hungry, you are satiated. Now, how many of you are comfortable injecting once a day? You all want to inject once a day? No? So the company is very smart. They say once a day, now we won't sell much. So let's alter this molecule further. So what they did was that they substituted another amino acid, alanine, to a fake amino acid at this position. They added a spacer. They added a longer fatty acid. The reason for this is because it doesn't get recognized by the enzyme that inactivates it. DPP4 does not see it anymore, so it doesn't inactivate it anymore. In addition, the binding to albumin becomes a lot more robust. And so instead of lasting 1 day, it lasts a week. So you need to inject this only once a week. Isn't that amazing? What science can do? There are a number of these molecules available. Am I going too fast on this material? Is it good? Okay, so there are a number of them available. Ozempic, which is for diabetes, Wegovy, which is for weight loss, it's the same drug. Rybelsus is the same drug, but it's available in oral form. We'll talk a little bit about it. Joe will have his mouth sealed. He can't talk about it. There is Victoza, which is Liraglutide, which is diabetic version. Saxenda, which is the same drug, but that's the weight loss version. And then there is this new kid on the market, and that's why I wanted Eli Lilly to be here, Tim Woods, Mounjaro. We're going to talk about that in a little bit. So the first thing I told you is that it slows down gastric emptying. The GLP-1 is released lower in my intestines, comes to my stomach and says, slow down your emptying. So here is the data. So gastric emptying time is much reduced in people on semaglutide versus the ones on placebo for the first 1 hour. So when gastric emptying is reduced, your satiety is improved. When you have a full stomach, you're less likely to eat, although sometimes I have seen myself eat even with a full stomach. All right. You also think less about food. Prospective food consumption when the stomach is full is less. Hunger is less. In this study, they asked these people a number of different questions. How often do you have food cravings? How difficult is it for you to control your eating? How often have you given in to a craving? How hungry did you feel? How often have you had cravings for fruit juice? How often have you had craving for savory food? All of these were impressively low. And many people felt full after a meal when they were on the drug compared to when they were on placebo. So the drug was better. But one thing out here is that how pleasant have your meals been? What that means is that did you really enjoy your food? If you take away the anticipation and the desire for food that you're going to eat, are you going to enjoy it? No. So you enjoy your food less on these drugs. And maybe we should do that because we have food in abundance and we are getting obese and we are not able to control our eating. Not only did that happen, not only did we eat less, felt fuller, more satiated, less hungry, but our blood sugars were lower. So in other words, the sugar levels went down compared to placebo. Because you were eating less and your sugar rise was less insulin needed to be made. Less glucagon was made because you remember what GLP-1 does? It goes and tells the pancreas not to make glucagon. Okay? Because you're eating less and because you are having slow gastric emptying, the amount of fat in your blood went down. The triglycerides went down. Now, fat is absorbed into our gut through a process called chylomicrons. Chylomicrons is fat-filled globules that we get. And the levels of chylomicrons was also lower. Okay, now let's go back. So what we have seen so far is that we've seen impressively that this drug works. It delays gastric emptying. It reduces your sugars, it reduces your insulin, it reduces your triglycerides, it reduces your hunger, it improves your satiety. So the next question that Novo Nordisk wanted to answer is that how effective is it in weight loss? Okay. So this is, let's backtrack a little bit. What Novo Nordisk wanted to know first is that how effectively does it reduce caloric intake? Do we know for sure that it reduces the amount of food somebody eats? So this is a study which is done in a small number of patients because it's a mechanistic study, 36, young people. They had a BMI that was 34. So again, they're about 70 pounds over their ideal body weight. The reason I put up this slide is because it's important for you to know how to take this drug. You cannot take the dose that you need right away. There is a dose escalation. So the first week you take 0.25 milligrams subcutaneously like insulin injection for the first 4 weeks. Then the next 4 weeks you go to 0.5, then the next 4 weeks to 1, and the following 4 weeks to 1.7 before you finally reach the dose of 2.4. So you don't get to 2.4 until the end of 4 weeks because dose escalation is needed for you to avoid side effects. What did they find? At 2.4 milligrams per week, there was a 35% reduction in caloric intake. Impressively, these people ate 1,000 calories less. And I'm rounding it up. It's 940 calories, but 1,000 calories is pretty close. They ate a kilogram less in calories. 1,000 calories less. Now, I've been telling you that it works on the brain. So this is some data that tells you that it works on the brain. So there are brain reward centers. And this group of people, they looked at brain reward system activation in response to GLP-1 and showed how it is reducing the brain reward activation. So this black line is people on GLP-1 agonists. This particular brain reward center, which is called the orbitofrontal cortex, the activation is less. This is another brain center called right and left putamen. The activation is less with the GLP-1 agonist. And these are another two centers called the left insula and the left amygdala. All of them are involved in reward and anticipation. They were activated less when you were on these drugs. So now we come to phase 3 trials. Now phase 3 trial is one in which the company says, we've done a lot of groundwork. We've seen that it works on the brain. We see that it reduces sugar. We see that it reduces gastric emptying. Now we want to test it in a number of patients and show weight loss and real benefit. So this is when they go to the FDA and show the results of this study and then say, hey, let's approve this drug. So in this, 1,300 patients in the semaglutide group, about 650 in the placebo group, young people, predominantly female sex, very high body mass index of 37. They were not diabetic because these were obese people. A1C was 5.7, which is borderline. About 45 were pre-diabetic, 45% were pre-diabetic. Let's not look at the cholesterol levels, but let's spend time on this slide. How impressive do you think that is? 17% weight loss at 68 weeks. Isn't that amazing? I mean, I feel so inadequate. I counsel my patients day in and day out, spend a lot of time. I would never be able to get such impressive weight loss. Fully 90% of patients lost 5%, 75% of patients lost 10%, 55% of patients lost 15%, and 35% of patients lost 20%. So if you were 200 pounds, you would be 160 pounds at the end of that year. Okay, now what did you have to pay for it? Now they calculated in a little funny way. So nausea, diarrhea, vomiting. So out of the 100 people treated for that year, 62% had some degree of nausea at some point or the other. 45 of them had diarrhea, about 37 had vomiting. These numbers are far lower in the other group, in the placebo group. So you had to pay a price for it. Now, pancreatitis, which can cause inflammation of the pancreas, happened in 3 people. The gallstones was a little higher. Gallbladder disease was a little higher, but the differences are minor. So I'm not going to say I don't want to prescribe this drug because of pancreatitis or gallstones or gallbladder disease. Let's look at some of the other impressive aspects. You had a 13.5 centimeter reduction in your waist circumference. That means you needed to buy pants that were 5 inches smaller. Isn't that impressive? 5 inches smaller. Blood pressure went down. Gene, you don't think so?
I mean, all I have to do is walk around the block 4 times and I can achieve the same thing without taking a drug and having side effects. So I'm, a little iffy on it.
Okay.
It's fascinating to trick the body, which is what that seems like to me. That's just
True.
My uneducated opinion.
You are a therapeutic nihilist like I am. Okay, the body weight loss average was about 15.3 kilograms, which is impressive. Now, this slide is meant to show you that the triglycerides went down impressively, inflammation went down impressively. So triglycerides, the fat was reduced, inflammation was reduced. Now, that study that I showed you was in people who were obese, were not diabetic. This study is, again, another important study, seminal study, that's looking at semaglutide in type 2 diabetics. And these people were also obese, about 400 in each group. There's a low-dose semaglutide, which is 1 milligram, which is used for diabetic patients. 2.4 is for obesity, but in this study, they looked at both. Again, sort of young. There is a little bit more even match between men and women. Again, they were very heavy, 35. Their A1C, instead of being normal like 5.6, was 8.1. What do you think about that? Mr. Salmon, isn't that impressive? 10% weight loss at 68 weeks in the high dose group, 7% in the low dose group. Okay, the change in A1C went from 8.1 to 6.4, a 1.6 percentage drop. That's impressive with the high dose group. 6.6 in the low dose group. Did not change. People remained at the same level of diabetes in the placebo group. So the question that you're having, that I had, is that what happens? You've taken this drug for long. Now you stop it. What happens when you stop it? Okay. So this study looked at that. So they started the drug at week 0, 20-week run-in phase, going up to 2.5. 800 patients started out this. And at 20 weeks, about 2/3 of them continued the semaglutide or Wegovy. The 270 people were switched to placebo. Okay? So treatment continued in one group, switched to placebo in the group, another group. What happened? What is your guess?
Placebo gained weight.
Gained weight. Okay, you're right. So you can see that the weight loss was there. At 20 weeks, they're divided into two groups. The weight loss continues in the semaglutide group. The placebo group gains weight, but impressively, they gain only about 70% of the weight back. They don't gain all the weight back. So something happened that helped them. Now, this is a very unusual trial. And I used to be at Baylor College of Medicine, and I used to run a lot of clinical trials. And this trial is a head-to-head comparison of Liraglutide, which is Saxenda, versus semaglutide, which is Wegovy. And usually companies do not want to do head-to-head trials because they don't want to show one drug inferior to the other. But in this case, there was nothing to lose because both Saxenda and Wegovy are made by Novo Nordisk. So they cannot lose because if one drug is shown to be superior. Okay, so they use the high dose of liraglutide once a day. So in other words, you're injecting once a day versus once a week. And impressively, semaglutide that you're injecting once a week was a lot more effective, 15.8% weight loss versus 6.4%. So actually, I'm doing good on time, and we're going to come to the end, and I'll leave some time for questions. Now, there is an oral semaglutide. People who don't want to inject, there's an oral version of that that's not available for obesity. But in this study, roughly 300 patients were divided into placebo and the oral type of medications. Predominantly female, very heavy, non-diabetic. Weight loss in this group is impressive, 15.1%. So the oral version of this drug, 50 milligrams, it's not yet FDA approved. It is called Rybelsus. It's approved for diabetes, but it's available, I think, in 3 and 14 milligrams. I may be wrong with the doses, but it's only for diabetes. It's not available in a 50 milligram tablet, which is what is needed for weight loss. And I think at some time, Joe will have a gag order. He can't talk about that drug, so you don't ask him anything about it. Okay, so what are the contraindications? What are the situations in which you should not use a GLP-1 agonist? If you're pregnant, likely to get pregnant, don't use it. There's a specific type of cancer called medullary cancer of thyroid, which is extremely rare. If you have it or have family history of it, don't use it. There is another type of rare cancer called multiple endocrine neoplasia. If you have that or have family history, don't use it. So I have to say that. But the most important thing is that I'm sure that, unlike Gene, many of us are thinking, I want to try this drug. Or am I that cynical that you guys say, okay, let me have a show of hands. How many of you would like to try this drug? Okay, so yeah, I mean, I'd like to try this drug. I'm sorry? Yes. Oh, thank you, John. But this is important. For those who want to try this drug, if you're taking insulin or if you're taking diabetic medications, they need to be reduced, because if they're not reduced, you will get hypoglycemic. So that's why this drug cannot be started without some patient education. You have to educate the patients about it. And Dr. Richard Bernstein, who is the preeminent person in diabetology, and I think many of you know about him, I don't know if Joe knows about him, he says that when you use a GLP-1 agonist, if you're using a high-carb diet, it doesn't work as well. That it works best when you're using it with a low-carb diet. So a little word about Mounjaro. Eli Lilly is absent. So this company came up with the idea that, hey, GLP-1 agonists are excellent. How about combining both GLP-1 and GIP together? And let's see what happens. So when they combined that, they created this drug called Tirzepatide, Mounjaro, and they used it in this study. This is again an impressive study. So about 600 patients in each group, 3 different Tirzepatide groups, 5, 10, and 15 milligrams, a placebo group. So in other words, there were 4 groups, young people, mostly female, body mass index 38, that means 80 pounds over their ideal body weight, non-diabetic, these were obese people, some of them were pre-diabetic, and like Wegovy or semaglutide, this is a once a week injection. What do you think? Anticipation. Okay, I would say it blew my mind. 21 to 22% reduction in body weight at 72 weeks. 22% compared to 2.4%. The 5 milligram dropped 15%, the 10 milligram dropped 19%, and the 15 milligram dropped 21%. Okay, these are also very impressive things, and I'll just summarize them. 28% drop in body weight. Quality of life better. Drop in blood pressure by 7 millimeters, so your blood pressures are better. Drop in triglycerides by 25 milligrams. Impressive. Nothing really drops triglycerides that well. HDL improved. Fasting insulin dropped by 43. I tell you, I cannot make people counsel them with fasting, exercise, and lifestyle and get such impressive results. So what are my concerns? You know, I'm right on time. So, and I've given, usually I don't give a favorable review of any drug. You know, I'm so skeptic that I always try to find wrong things with it. So I've given a very favorable review, and I'm willing, after proper patient education, to try it in some of you. So I have gone to that step, and that's why I wanted to take the time to learn it and tell you about it. But what are my concerns? So there is this thing called agonist-mediated receptor downregulation. It's a mouthful, right? Agonist is the drug. Receptor is the receptor on which the drug acts. And when maybe this slide will help better. So this is the agonist. It goes and sits on the receptor. The receptor gets activated. Then the receptor, after activation, gets into the cell. So it gets what is called endocytosis. And once it gets into the cell, it can either be recycled back, or more commonly with persistent stimulation, because this GLP-1 in our body is naturally designed to be there just for a few minutes. But now you are activating the GLP-1 receptor continuously for a year. So your receptor in the brain and other places can get downregulated. And the way downregulation happens is that this receptor gets into the late endosome and then the garbage disposal mechanism of the cell, which kind of degrades the protein, which is called the lysosome, and less number of receptors will be available. Do you guys know of a common entity in which the receptors get downregulated? Have you guys heard about opioid addiction? So opioid works on the opioid receptors. The first time you take an opioid shot, it causes pain reduction dramatically. The second time you take it, it's less effective. 1 month later when you take it, you're only taking it just to feel normal. Because the number of opioid receptors keep going down the more you take that drug, so that drug becomes less effective. So you would think that a large number of scientific community is looking at GLP receptor downregulation. Do you know, I spent 1 day trying to find a study that's looking at GLP-1 downregulation with over a year of use. How many studies do you think I found? 0. And the reason for that is perhaps there is no interest in anybody funding this to find it out. So what are my final thoughts? I'm willing to consider these drugs because they've been around since 2005. So we roughly have about 20 years experience with them. They definitely reduce appetite, hunger, and improve satiety. Their weight loss is impressive. I cannot say I cannot say how impressed I am about it. It definitely improves sugar and makes insulin work better. It reduces triglycerides. It improves the good cholesterol. It reduces inflammation. And for many people, many of my patients have come and struggled. They said, "Doc, I've tried everything and I'm not able to lose weight." This might be a decent alternative. Now get ready for this. It's expensive. If your insurance doesn't cover it, and very often insurances are not going to cover it, they're going to find every reason to deny you of this. It's going to cost you $12,000 to $15,000 a year. So Joe, can you keep my office stocked with samples? Can you answer that or no? Yes, okay. All right. Okay. Awesome. Oh, what could be better? Wow. Weight gain after cessation. There's no research on GLP receptor downregulation. Nausea, vomiting is there. I'd like to see the pill form being approved by FDA. They're going to take their time, I guess. And it may take, I'm scared that it might take the incentive from several people saying that, hey, this is an easy way out. I'm not going to do lifestyle. So thank you so much. That's all I have. I would be happy to entertain some questions if you have.